So when I think medial epicondyle, I'm thinking flexors anterior compartment. When I'm thinking lateral epicondyle, I'm thinking extensors posterior compartment. So very broadly in my mind, that's kind of how I've got it broken up. And there are a lot of muscles in there, so don't get me wrong, there are 11 muscles back there that we got to talk about. Like the anterior forearm, they're kind of arranged nicely. So they're grouped together in functions or nerves. And they're grouped together broadly into two categories, like a superficial posterior compartment, and then there's a deep layer in the posterior compartment. When I think posterior arm and I think posterior forearm, I'm thinking about the radial nerve. The radial nerve. When I think radial nerve, my next thought is posterior forearm. They're that closely tied together, I would say. So the triceps muscle we mentioned, innervated by radial nerve, and all these muscles distally, okay, down here on the extensor or posterior side of the forearm, many arising from the lateral epicondyle, are innervated by the radial nerve or one of its derivatives that we'll discuss. So radial nerve injury, you're thinking consequences as far as extension of the wrist, extension of the digits, which are some of the primary jobs of these muscles we'll discuss. So superficial and deep layer. And they're coming from lateral epicondyle, which would be out here. So lateral epicondyle out here. There's olecranon. There's medial epicondyle. There's cubital tunnel. That's cool. Got to be, right? That's ulnar nerve. Right there, cubital tunnel. All right. So we'll start with the superficial compartment. Break these up like this. We'll first talk about some radialis muscles on the superficial side. So remember, if we're talking about the cubital fossa, on the medial side of the cubital fossa, boundary is pronator teres. On the lateral side of the cubital fossa, boundary is brachioradialis. And that's coming from this lateral side out here. So the brachioradialis, you can see the muscle coming off really high. It's technically a little higher than the lateral epicondyle. It's up on that lateral supracondylar ridge. And you can palpate it. If your forearms are exposed right now, you can take some fists like this and almost kind of lift up on, put your fists underneath the table as though you're trying to lift it up and flex a little bit. And you can see it. You can see the brachioradialis muscle pop up like this. The brachioradialis muscle is, I like it, it's technically an elbow flexor. The first thing it wants to do, though, is pull your hand into like this mid-pronated position. Okay, so if your hand is supinated like this, brachioradialis tries to first get you into this position and then flex your elbow. If you're fully pronated, brachioradialis tries to get your hand into this position and then flex your elbow. So we call it the beer drinking muscle. Right, so in order to hold the cold one, you got to have your hands kind of like this, mid-prone, mid-supine position. So brachioradialis. Working our way down after brachioradialis, I see two extensors here, very important, wrist extensors, carpi referring to the wrist. These are on the radial side, so this is a good name for them. We see extensor carpi radialis longus, going to base of second metacarpal, and extensor carpi radialis brevis, going base of third metacarpal. Okay, ECRL, ECRB. So these are going to be wrist extensors. Okay, these are innervated by radial nerve in the case of ECRL, and then a branch of the radial nerve we'll discuss later in greater detail called the deep branch. All right, so that's it. Those are the radialis muscles. We did it. So we see brachioradialis, ECRL, extensor carpi radialis longus, ECRB, extensor carpi radialis brevis. And they're going to be helping, in the case of brachioradialis, with this elbow flexion after this little mid-pronation kind of negotiation. And then for extensor carpi radialis longus and brevis, they're going to be wrist extensors. Kind of like on the front side, though, since they're on the radial side, they can also help with a little bit of radial deviation. All right, radial nerve, baby, radial nerve on the back side. You get to know radial nerve really well. Okay, so after we get done with those, we can move more medial across the forearm toward the pinky side. We see this big guy. So this is extensor digitorum. So on the front side, we saw flexor digitorum superficialis and flexor digitorum profundus. So on the front side of the forearm, you have two digital flexors, superficialis and profundus. On the posterior side of the forearm, you have one. So you have extensor digitorum. This used to be called in the old days extensor digitorum communis. There's just one giant extensor here. You don't have a superficialis and deep. Okay, so naturally extensor digitorum is going to help with digital extension. It crosses the wrist joint, as you can see, so it can't help but act on the wrist a little bit. So it'll help extend the wrist, and it'll help extend the digits. The way these insert, interestingly, the way extensor digitorum inserts is it goes into this large sort of fanning expansion on the back of your fingers. On the back of your fingers, they're different than the front of your fingers. On the back of your fingers, you have this fairly complicated fibrous tendinous kind of network that comes out to a fan, like this big bright white fan on either side of the kind of at the base of your fingers. And they call this the dorsal expansion or the dorsal hood. So the extensor digitorum muscle will insert into the extensor expansion, thereby extending the digits. Extensor digitorum also has a little, like an accessory belly that comes off the side. So it's literally off the side of extensor digitorum. We see a muscle called extensor digiti minimi. And the extensor digiti minimi is like a secondary, completely unique extensor of just the little digit, digiti minimi. Okay, so extensor digitorum also going out. So this is, notice, digits 2 through 5. It's kind of a trend, right? So on the front side, flexor digitorum profundus and superficialis, just the digits 2 through 5. On the back side, extensor digitorum, just the digits 2 through 5. So the thumb is its own deal. And remember, this accessory belly, extensor digiti minimi, is an additional one, a second one that will also go to digit 5 to help extend the little finger, okay, the fifth digit. These are innervated by PIN, posterior interosseous nerve, which is a branch of, ultimately, the radial. All right, and we worked our way all the way across now, and we see extensor carpi ulnaris. There's that name again, carpi, referring to the wrist. So I would not expect this one to flex the digits, but I would expect it to act on the wrist. I also expect it to be on the back, so it's an extensor, and I expect it's going to be on the medial side, so we call it extensor carpi ulnaris, or the ulnar side. So extensor carpi ulnaris coming down, crossing the wrist joint is going to help with extension of the wrist. Now, if you kind of bear with me here, this is a bit of a complicated picture, but it makes sense. So if we're on the front side, we saw this is sort of lateral over here. This is medial. So we mentioned a muscle here. This is on the front side. So flexor carpi radialis and flexor carpi ulnaris. We know those flex the wrist, right? So if they act together, flexor carpi ulnaris, flexor carpi radialis will act to flex at the wrist joint. Similarly, on the back side, extensor carpi ulnaris together with ECRL, extensor carpi radialis and brevis, if they act together, then they will act in extension. Now, I could use these muscles on either respective side to perform deviation. So if I use just extensor carpi ulnaris, like we see in this picture, together with flexor carpi ulnaris, which is on the medial side of the anterior forearm, okay, then their relative pulls here will be to kind of cancel each other out and go out pure medially here. So we call this ulnar deviation. So if I use the front one on the medial side and the back one on the medial side, and I pull them together, then instead of going forward or backward, they kind of go straight out. Does that make sense? So that's how we get ulnar and radial deviation, respectively. Okay. Just a table summarizing these: posterior interosseous nerve, branch of the radial nerve. So you can see if you got a radial nerve injury up really high, and the posterior interosseous nerve, which is a branch of the radial, was affected, then all these muscles are going to lose their tone, right? You're going to lose all these muscles. So wrist extension, digital extension, all that's going to be busted. All right, so move into the deep compartment now. So the deep compartment muscles, the first one I see here is the supinator. So when I'm thinking the posterior compartment or the extensor compartment of the forearm, I do have a supinator back there to help. Remember, which muscle is your primary supinator? Anyone remember? Biceps. Yes, the biceps brachii muscle is your strongest supinator. So if you're trying to open your hand up like this and roll that radius over so you're in the supinated position, biceps is the strongest one to do that. You do have a backup though. So the supinator muscle is just called the supinator. It's great. Will assist with that. And another one that I have labeled on this one's also, this is in the deep compartment. So the extensor digitorum muscle has been removed. And I can see, like we had a unique muscle going to the fifth digit, extensor digiti minimi, we also have one for the index finger, extensor indicis. Okay, extensor indicis, referring to the index finger. So extensor indicis there. And okay, good. So something I want to point out. So the radial nerve is coming down. The radial nerve kind of wraps around your humerus, kind of like a stripe on a candy cane. So it's wrapping around the posterior humerus about mid-shaft. That's why mid-shaft fractures can affect the radial nerve. And it ends up wrapping around the lateral epicondyle. So if you just palpate it out here on the lateral side of your elbow, that lateral side of your elbow is right around where the radial nerve will split. And the radial nerve will split into a superficial branch and a deep branch. The superficial branch of the radial nerve is a pure cutaneous sensory nerve that goes all the way out to your hand. So if I come out here and I snipped the superficial branch of the radial nerve right around the elbow, then I would lose sensation on the back of my hand on its lateral side here. We'll discuss this again later. The deep branch of the radial nerve is like the motor part, okay? So we can see the deep branch of the radial nerve passing under the supinator, or sometimes in this case drawn as passing through the supinator. So there's that superficial branch going down toward the hand, sensory only. The deep branch of the radial nerve will go either under or through the supinator. It's going to pass deep to it, at least at some point. And after the deep branch of the radial nerve pops out, we call it the posterior interosseous nerve. So that's where that nerve comes from that I mentioned. That's pretty much it. I mean, there's not too many crazy branches with the radial nerve. So radial nerve wrapping around the humerus, splitting into superficial branch, which is a cutaneous sensory branch for the hand, and then the deep branch of the radial nerve, which is a motor branch. The deep branch of the radial nerve passes under or through and then out of the supinator muscle and changes names to the posterior interosseous nerve. Okay. All right, so now let's talk about other muscles in the deep compartment which are involved with your thumb. So if I'm working my way down the radius here, the first one that I'll see is abductor pollicis longus. And the abductor pollicis longus is going to be abducting the thumb. So when I hear pollex, I'm thinking about the thumb. And it's very good friends with this smaller muscle. The artist is taking a little bit too much liberty here. It's nowhere near, the tendon is nowhere near the size, it's tiny. This is the extensor pollicis brevis muscle. So abductor pollicis longus running together with extensor pollicis brevis. They run together in a common little sheath. And I can palpate where these are at here, right on the radial side of my thumb. They run together. So thumb abduction, thumb extension. And then I see a muscle, oh, here it is, wrapping around the dorsal tubercle, Lister's tubercle. So on the back of the radius here, I see extensor pollicis longus tendon wrapping around. And I'll see the extensor pollicis longus tendon go all the way to the distal phalanx for extension of the thumb. So they call these the outcropping muscles because they sort of stick away from your forearm going towards your thumb because your thumb kind of sticks out. So these outcropping muscles activate your thumb. So abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus. There's extensor indicis that was labeled in the last slide, going to the index finger. You can usually see the extensor indicis tendon rolling around over the extensor digitorum tendon. So if you make a fist like this and you extend your index, I can see mine really well. I don't know whether it's getting old or what. I can see it. You see it, you can kind of feel it maybe, that tendon just rolling around. So you have two dedicated for your index finger and then two dedicated for your pinky finger, which is cool. All right, so actions of the thumb. We got to get this down. So thumb is a little bit weird. So let's do this together. So everyone look at me. So if I were to say, okay, flex your fingers, what happened to your fingernails? Nails go down. If you extend your fingers, nails come back. So I want you to consider your thumb now. Consider the thumb. The thumb, in a healthy person, your thumb is at 90 degrees to your row of fingers. Do you see that? Your thumb is like this, and your fingers are like this. It's supposed to be this way. Your thumb is not in line with your fingers like that. It shouldn't be like that. It's off to the side. So because of that, if I flex my thumb, nail goes down. Nail going down, this is flexion of the thumb. If I extend my thumb, nail comes back. So thumbs up is extension of the thumb. Extension. I can see my extensor pollicis longus tendon active there, pulling my thumb into extension. Now, abduction of the thumb is your thumb in its natural little orthogonal plane moving out. So abduction of the thumb is like making the letter C with your hand. So if I said, okay, make the letter C with your hand, you would have to get your thumb out like this to do it. That's abduction of the thumb. Does that make sense? So abduction. Abduction of the fingers is just spreading them apart like this. Adduction is like adding them back. So if you make a C with your thumb, that's abduction, and then of course adduction would just be bringing it back. The final movement we can do with our thumb, which is the reason why we have iPads and the other apes don't, is because we can oppose our thumb. So opposition of the thumb is whenever we swing our thumb around, such it's a combination movement, such that the pad of our thumb is facing our palm. So it's like a combination of abduction and flexion. So this is opposition. Cool, thumb movements. All right, so these are the muscles. These are the ones, the deep layer we just mentioned. We mentioned the supinator and extensor indicis, and then we had a separate part of the deep layer called the outcropping muscles. We notice, again, just to hammer this home, all of these are innervated by the radial nerve derivatives, either the deep branch of the radial nerve, or after it changes names, popping through the supinator, the posterior interosseous nerve, again, which is just the continuation of the deep branch of the radial nerve. So you can imagine all the thumb problems you might have, if you don't have a good radial nerve intact. Good. Okay, just some extras along the posterior forearm here that we have to talk about. First is the artery. I just want to just bring your attention to this sort of the logistics of this. So this artery is what? It's not labeled, but you should know. Yeah, the brachial artery. So with the exception of our little anastomotic connections, which are tiny, going around the elbow, this is the guy. He is the one. The brachial artery, it's up to the brachial artery to get blood to your fingertips. We're not piping giant arteries on the backside. We're not hiding them anywhere else. If you want to get blood to your forearm and your hands and your digits, your brachial artery has to be patent. Super important. So just consider what has to happen now. The brachial artery splitting into radial and ulnar. We see radial on the lateral side, ulnar on the medial side. These are just perfusing tissues as they pass through. So all of the tissues kind of on the medial or on the lateral side here, the brachioradialis, extensor carpi radialis longus, brevis, as the radial artery is passing them, as any artery is passing through tissues, you can assume that it is throwing small little branches into them. And that's why I don't include an artery on all these muscle tables. The anatomy textbooks don't do it. We just don't do it, okay? So arteries are more, in a more sophisticated understanding of an artery is like where it's located, it's perfusing regions, where anatomically could it be in trouble, like which arteries in the quadrangular space, stuff like this. That's the way to think about arteries. And if you look at the ulnar artery, which is way bigger than the radial artery, it'll give off this branch that I mentioned last time, a common interosseous, right, which splits into the anterior interosseous on the front side. And then look, the posterior interosseous on the back side. That's super important. So a lot of these muscles on the posterior side rely on the posterior interosseous artery, and I see it here illustrated on the back side, for blood supply, because we don't have a big fat artery back here, right? The big fat artery, the brachial artery, is on the front side. So we have to be kind of creative about how we get blood back there. So we use this system, common interosseous splitting into anterior and posterior interosseous. In the posterior interosseous, they're just sneaking behind the interosseous membrane, popping out and helping with some of those muscles on the backside. Okay. Cool. And then also just a review of who is innervated by what. So let's see what I labeled there. So what I would know is, I didn't mention this muscle. So there is this muscle back here. It's called anconeus. So anconeus is a bit of a, it's not terribly important back here, but you can feel the anconeus if you take your fingers to your olecranon process and move them just lateral, just lateral, like on the side of your olecranon process. There's a little triangle-shaped muscle right there called the anconeus muscle. You can feel it really well if you pronate really hard. So if you pronate like really hard, you can feel it like wad up. That's anconeus. So it is technically helping with pronation a little bit. And since it does cross the elbow joint, it's a very weak elbow extender, but low yield anconeus. Okay. Good. Okay, so all these are the radial nerve derivatives that we discussed: deep branch, posterior interosseous branch, innervating these muscles. We can see that posterior interosseous nerve is popping out underneath the supinator. So remember, the radial nerve, not seen up here, would be splitting into superficial and deep branches, and The deep branch would go under the supinator here and then pop out and change names to the posterior interosseous nerve, innervating any of these. Okay. Two very important clinical takeaways here, pretty high yield, I would say. This gets assessed in the clinic all the time. It's medial lateral epicondylitis. So remember, when we think medial epicondyle, we're thinking the flexor side, anterior compartment, flexor origin. A lot of these muscles, like if you're dissecting someone's forearm, the tendons, they'll kind of fly apart like this. If you're cutting them, those kind of fly open like this. And they sort of converge on a single like muscular wad going toward the medial epicondyle called the common flexor origin. And at that point, you can't really separate the muscles very well. It's almost like they work almost together from this common flexor origin. So if you're doing a lot of activities here that could irritate that, they call this golfer's elbow, wherein you're like stretching or irritating overuse of these flexors, then you can develop an inflammation at this bony site where everything is attaching. Okay, so flexors of the wrist being superactive or pronator being superactive right there can result in medial epicondylitis. Golfer's elbow. And just the opposite of that is tennis elbow. So tennis elbow is lateral epicondylitis. So you're thinking strain or exertion on the extensors, largely, not all, but largely coming from the lateral epicondyle, okay, from the lateral side. So you can develop a little inflammation on the lateral side if you're like backhand. Is this backhand tennis? Something like that? Pickleball, whatever. Not a pickleball thing. You have pickleball players in there? Don't be ashamed of it. It's fun, right? Good. So if you're like extending a lot of the wrist, then you could be irritating those muscles. So lateral epicondylitis versus medial epicondylitis. Okay, so on the dorsum of the hand, it's a very important anatomy that we need to wrangle with. The first thing I'll point out is this nerve. So this nerve going on to the back of the hand, this is the SBRN stands for the superficial branch of the radial nerve. Not a new nerve, I mentioned it already. So the superficial branch of the radial nerve is providing cutaneous sensory information to the lateral side of the dorsum of the hand, or the back of the hand. So notably digits 1, 2, and 3. Okay, so if you lost sensation, like right here on the back of your hand, there might be something wrong with your superficial branch of your radial nerve. All right, some tendons I can see. Everyone can probably see the tendons of their extensor digitorum muscle. This one I want to point out. So Lister's tubercle on you would be right about here, where the radius would be. And then the extensor pollicis longus tendon wraps around that. So this person's thumb is in which position? What would you say? Extension, flexion, abduction, what would you say? Extension, like thumbs up is extension, right? So they're in extension. So the tendon of their extensor pollicis longus here is active. And I can see it would be wrapping around Lister's tubercle, which would be palpable right about here. If I go lateral to that, I run into this little pocket. And then if I come right out of the pocket, I can feel another tendon. Okay, so that other tendon, which is right here, it's actually two tendons. It's the tendon of abductor pollicis longus and extensor pollicis brevis. They run together. And they form an important little pocket here. So between the extensor pollicis longus tendon and those two tendons, the abductor pollicis longus and extensor pollicis brevis, we call this the anatomical snuff box. Okay, so back in the day, people used to do snuff or whatever, and they used to allegedly keep it in here. So kind of like pack it into there before they use it. Just forms like a natural little pocket. I don't know what people would put in there now. Zen packets maybe, something. Cool. So more on the snuff box later, especially when we talk about the hand. The radial arteries passing through the snuff box, so it's a pretty important little area here. Okay, so how are these things arranged on the back? So this is very similar to a picture I showed you on the front side. So on the front side, we see all these little synovial sheaths. Same deal. So all these little blue things are illustrating these synovial sheaths on the posterior side. And something that I'll draw your attention to is this retinaculum. So the extensor retinaculum, kind of like the flexor on the front side, this is a thickening of the antebrachial fascia. So all that they've done here is, remember, if you take someone's skin and fat off, you don't see these muscles straight away, right? You have to cut through the fascia. So don't forget about the deep fascia. So if you were to cut through the antebrachial fascia, you could trim it away kind of close to the wrist like this. And you would in a dissection course normally. So you can leave this little area over the wrist called the extensor retinaculum. So the extensor retinaculum, very thick, and it will invest at certain points and have connections to the bones, as you can see here. So this is like an axial section showing you these. And these little tendons will pass through these little tunnels. So there's like dedicated little tunnels for these, and there's 6 of them, actually 6 of them. So the one I mentioned that we mentioned actually before, there's a dedicated pocket for abductor pollicis longus and extensor pollicis brevis. That was the lateral side of the snuff box right here, right? Those 2 tendons that we felt. We have 2 radialis muscles acting together. Remember, extensor carpi radialis longus and brevis. I can see those here, number 2. 3 is EPL, so extensor pollicis longus. 4 is extensor digitorum, and then also extensor indicis. You get a little accessory belly. And then extensor digiti minimi gets its own pocket. This is always fun to find in dissection. People are always trying to pull on it and find it, but it's always buckled down. And then lastly, extensor carpi ulnaris. So I would know these individual little pockets. So the orthopods are all about this. They know all about who's going where. The synovial sheaths lining these can also sometimes they can get infected. They can become inflamed. They can pass infections back and forth via the synovial lining, like from your forearm into your hand and stuff like that. So pretty important little pockets there. And these just act like pulleys to help the muscles work in the directions that they're supposed to work by buckling them down a little bit. So you can see a picture in a couple of cadaveric specimens, a really clean Rowan's image here of the extensor retinaculum. And then they sort of highlighted, they color in blue here where the synovial sheaths would be. Okay. A very, very relevant anatomical topic to talk about back here is a ganglion cyst. Anyone ever have one of these? Yeah, I get one too. It just kind of comes and goes. So these synovial sheaths can also be relevant because they can develop little bubbles or cysts that are filled with just the synovial fluid. And they can be painful. Sometimes they can be excised if they get bad enough. Well, they'll just go in there and snip it and take it out. But they're just filled with a synovial fluid. They're just like a defect in the synovial sheath on the back of the hand. It's normally on the dorsum of the hand, on the lateral side, kind of right about there. I get one on my left hand. That's normally where it's at. It kind of hurts if I go into some extension, but it'll eventually go away. The old way of getting rid of these is just to hit it with a book. So it's just like smashing it like this to try to pop it, which is pretty wild. But it usually clears up on its own. Okay, now as I mentioned, the anatomical snuff box. Let's dive into that a little bit more. So there's extensor pollicis longus, and these 2 tendons together, abductor pollicis longus, extensor pollicis brevis. Those are the ones that you can see on yourself, and it makes that little pocket. So the little pocket would be located right here. And relevant features of that pocket, all the way down inside, we would see the radial artery. So that's probably the most important component down in the anatomical snuff box. So the radial artery would be down inside. And then passing over the top of the snuff box, we would see a branch of the superficial branch of the radial nerve. So this is the superficial branch of the radial nerve coming across. And this territory here in pink on the back of your hand, that cutaneous sensory territory is supplied by that branch, the superficial branch of the radial nerve. Remember, it's cutaneous sensory only. So it passes over the anatomical snuff box. Also, the origin of the cephalic vein normally passes over the anatomical snuff box as well. Okay, neat. A pretty important little area there. All right, just a review here of the radial nerve. It's kind of the most famous nerve in this lecture for sure. So the radial nerve, if you remember, all the way upstairs. If you can do the brachial plexus, you're doing pretty good. So the radial nerve coming off the posterior cord producing the axillary nerve, radial nerve. The radial nerve, as we can see in the picture on the left here, is passing behind into the triangle interval, behind the shaft of the humerus in the triangle interval right here. So mid-shaft humeral fractures, we're worried about radial nerve. Surgical neck fractures, we're worried about axillary nerve, right? So that's something we mentioned last time. So radial nerve passing in the right, it's usually applied straight to the bone. Like when I find it in lab, I can peel apart the heads of the triceps. It's laying right on the bone. It's chunky. It's a big nerve. It's a really big nerve. And the radial nerve innervates the triceps muscles, as we mentioned, passes down and will split into the superficial and deep branch. We see that right here. So passing down close to the lateral epicondyle will split into the superficial branch, which is pure sensory. So that sensory branch would just do the hand, just down here, superficial branch of the radial nerve. There is a nerve that comes off the radial and will go to the skin of the posterior forearm. They call this the posterior cutaneous nerve of the forearm. So this would do to the level of the wrist, right about there. So the posterior cutaneous nerve of the forearm would be right about here, whereas the superficial branch of the radial nerve would just do the hand, just like that. We remember the deep branch of the radial nerve passes onto the supinator, okay? Innervates a couple of muscles there, usually supinator and extensor carpi radialis brevis, and then becomes the posterior interosseous nerve, which will do all the remaining muscles in the posterior forearm. All this may be academic. If you have a really high radial nerve lesion, all this is shot, right? Your superficial branch of your radial nerve is shot, so you would have a loss of sensation on the back of the hand here. If it comes off before, if the lesion is higher or proximal to the posterior cutaneous nerve of the forearm, you'd lose sensation on the back of the forearm and elbow like this. All the muscles we discussed today, you would lose action to them in the posterior compartment. So radial nerve injury can be devastating. So just to hammer this home, remember the radial nerve in the triangle interval. The triangle interval is at risk during mid-shaft humeral fractures. Two contents of the triangle interval, of course, the radial nerve and the deep artery of the arm, or profunda brachii. So this is kind of your patient profile, just like this. And grossly, I mean, you can test them out. You can see, oh, their outcropping muscles aren't moving very well. You can do a sensory test on them. And if you knew the territory of the radial nerve, if you had that picture in your mind of the red territory we just looked at, that would be affected. The big sign they talk about a lot is wrist drop. So they would come with a wrist drop. So remember, all of your muscles all the time are always trying to act. You can't shut your muscles completely off. All of your muscles always have some kind of tone. And if you have a joint that acts in opposite directions, for example, your wrist, which can flex or extend, if you disconnect all the extensors on the backside, the flexors are ready for that. The flexors are like, all right, this joint is mine now. And they're going to pull your wrist into flexion. You can't stop it because there's no tone. There's no tone that on the backside. So the mere tone from the front muscles will pull you into this position. Does it make sense? So wrist drop is very common with radial nerve lesion. This can also come, just another kind of patient profile, is damage in a similar way with the same kind of symptoms. So this person has a wrist drop here, I think, yeah. So this is the affected hand. They're asking this person to extend the wrist. So on the left side, you can see it's working. On the right side, it's just not working. So they're stuck in this wrist drop position. Another way this can happen is with what they call Saturday night palsy. I don't know how big of an issue this is anymore, I guess, but it's always the same. It's always written out the same way. So like the patient presents after a long night, a little bit too much fun at the bar or something like that, and they fell asleep, aka passed out with their arm draped over a park bench or their arm draped over a chair or something at the bar. And their arm being draped over the chair on the back acts kind of like a mid-shaft humeral fracture, except for instead of fracturing the humerus, it's compressing the radial nerve against the humerus and causing it to get angry. So it's compressing the radial nerve and giving you the symptoms of a radial nerve lesion. Does that make sense? It's radial nerve injuries. So that's all I've got. I'll stick around to answer questions if you have any on the posterior forearm. A little easier than the anterior forearm for